Hello guys, welcome to our channel. Today we are going to discuss about the medicine part 2 rapid revision. In this rapid revision, we are going to cover the cardiology, nephrology and the endocrinology, most important PYTs. So let's start our discussion with the basics, then pathology. So before that, please do subscribe and share with your friends. Please make it the 1K subscribers, and soon these videos will be recommended to the more students and will be helpful for the each and every students. And next, moving on to the discussion, first we are going to discuss the basics of the cardiac cycle. So what is the basics of the cardiac cycle? When I say your first event will be rapid filling of the ventricles. So rapid filling of the ventricles will be happening when there is a mitral and the tricuspid valve is open, right? When the valve is open, the both ventricles will be filled. After that, there is an event that is known as the isovolumetric contraction. Near this contraction, mitral valve and the tricuspid valve will be closed. This is leading to your S1 sound. Okay. So the first heart sound is occurred at the isovolumetric contraction. All the valves is closed. So the tension is increased, which will lead to the opening of the aortic and the pulmonic valves. Okay. These both valves will be open. And here your rapid ejection will be happening. It's continued by your slow ejection, and then it will be reaching to the isovolumetric relaxation. And in the isovolumetric relaxation, you will be seeing that both the aortic and the pulmonic valves will be closed. Okay, this will be leading to which sound? That is your S2, the second heart sound at the isovolumetric relaxation. And again, this cycle will be continued here. Again, the rapid filling will be the mitral tricuspid open, and again, isovolumetric contraction, rapid filling, rapid ejection and the slow ejection. So this is what the entire cardiac cycle with the S1 and S2 sounds will be forming. So in between only, we will be having this graph, which is the most important pressure and the volume graph of the heart. How this graph should be interpreted. So same events we have to remember. This is the point A. At the point A, there is a diastolic filling, right? The mitral valve is open, right? In this mitral valve opening, the filling will be happening. So the O volume is increasing in the ventricles. Once they reach the 1 point, like 120 ml, and this will be causing the pressure. Okay, the pressure will lead to isovolumetric contraction. And here the mitral valve is closed. This is the event for the first heart sound, S1. And then this isovolumetric contraction will reach some pressure, which will be leading to the systolic ejection. Your both aortic and the pulmonic valves will be opening, and both the ventricles will be pump the blood to outside. And here this is the C event. And next the event is the pressure is going to down, because the whole blood of the heart is ejected outside, right? That will be leading to your D point, that is the aortic valve closes. Here your S2 sound is coming here. And then again isovolumetric relaxation. This is also like all the pressure is decreased, leading to the mitral valve opening and also diastolic filling. So this is the pressure and volume graph loop. And next, moving on to the cardiac myopathies. So cardiac myopathies is also commonly asking question. Let's understand how they are and what are the types. So we have the three major types. The most common overall is the dilated cardiomyopathy, followed by your hypertrophic cardiomyopathy, and next to that is the restrictive cardiomyopathy. So what does mean by the dilated cardiomyopathy? Here you can see the heart is completely dilated, right? Heart should be having a more muscular structure. But in this picture, if you see, there is a less muscular structure and heart is dilated in the all sides of the valves. So this will be seen on the echocardiography as a symmetric and hypokinetic. What does mean by the hypokinetic means? There will be a no movement. So less movement is seen in the dilated cardiomyopathy. How much it is dilated? More than 6 mm. Okay, more than 6 mm dilatation of the heart will be seen in the symmetrical. All the four sides will be symmetrically dilated. And what are the causes for the dilated cardiomyopathy? The most common cause in the worldwide is the alcohol, and then followed by your peripartum. The pregnancy patients, peripartum, and those who are in the malnutrition due to deficiency of the selenium, and those who are with the cocaine abuse. All this will be the multiple causes. Along with that, there will be also causes like sarcoidosis and also hemochromatosis. You may confuse that hemochromatosis or these both are going to be the buildup of the muscles, but buildup of the protein or some other substances like iron. Why this is considered to be in the dilated cardiomyopathy? So comparing to these, both are common in the restrictive cardiomyopathy also, but more common in the dilated cardiomyopathy, because restrictive is very rare. That's why it is morely seen in the dilated cardiomyopathy only. And also some of the medications can also cause the dilated cardiomyopathy. That is your doxorubicin. Okay, these drugs are also asked in the pharmacological. The doxorubicin is a heart toxicity. And by genetic causes, if we mention the genetic causes, this is due to deficiency of the titin. So titin protein deficiency that will be causing the dilated cardiomyopathy. And also Duchenne muscular dystrophy, the patients, those who are suffering from the genetic conditions. And how these patients will be presented. In the patients will be presenting with a systolic heart failure. Okay, due to hypokinetic, right? What we discussed, both the four valves will be symmetrically dilated and there is a systolic failure, and which will be presenting as a symptoms. What is the treatment of the choice? What we discussed here, alcohol is the main cause, peripartum is the main cause, cocaine, selenium, all this will be underlying causes only. So treat the underlying causes. Okay, treat and supportive treatment. The patient is presented with a systolic heart failure. Give the patient according to the failure symptoms only, right? Next, moving on to the hypertrophic cardiomyopathy and how the hypertrophic cardiomyopathy is seen in the echocardiography. This will be seen as the hyperkinetic and asymmetric. Okay, so the function of the heart should be normally a normal kinetic mechanism should be seen, and again the all the valves will be symmetrical only. But here if you see, this is at the one kind of shape and this is having the different kind of the shape. So this is what they're mentioning in the asymmetric type of the heart structure. And in this hypertrophic cardiomyopathy, the patients will be having the symptoms mostly due to diastolic heart failure. Okay, they will be having the diastolic heart failure. And what are the causes? Completely, this is the only condition that is 100% genetic condition. Okay, regardless other chances, this is only caused by the genetic conditions only. And what is the most common one? That is the beta myosin. Okay, beta myosin. If you see the histology, in the histology, this patient's heart biopsy will be showing the muscle arrays. Okay, disfigured muscle arrays will be seen due to beta myosin deficiency, and this is suddenly leading to the sudden cause of death. What is the sudden cause of death? Because of hypertrophic obstructive cardiomyopathy. Why the obstruction is seen? Here you can see the valve is completely closing. If this valve is closed, what happens? It cannot eject the blood from the aorta. That will be leading to the sudden cause of death because the tissues cannot reach the blood and causing the ischemia or sudden cause of death in this patient. So the patient, if they die due to unknown causes, most likely to be the hypertrophic cardiomyopathy. What is the treatment? This is the hyperkinetic, right? What you can do? Rate control. Okay, do the rate control for this patient. And next, ablation. What you have to do? You have to just ablate this muscle. This extra muscle, na, you have to ablate. So then there will be a decreasing of the chances for the sudden cardiac death. Next, moving on to the restrictive cardiomyopathy. Restrictive cardiomyopathy will be the akinetic and the asymmetric. Okay, why this akinetic or the asymmetric condition? In the akinetic, due to the causes like amyloidosis. What is the amyloidosis, guys? We all know that amyloidosis is the type of amyloid protein that will be deposited in the tissues. If it is deposited in the tissues, now the entire heart valve will be unable to pump past the blood. So this is leading to the akinetic mechanism. Along with that, this is the most common one. Along with that, you will be having the secondary causes like LSD, lysosomal storage disorder, or the glycogen storage disorders, and even the patients, those who are suffering from the radiation, the post-radiation, this can also cause. And same with the sarcoidosis and also hemochromatosis can also be causes of this restrictive cardiomyopathy. And how this patient is presented? Biventricular, because both the ventricles are not working right, akinetic mechanism leading to the biventricular heart failure. And ultimate treatment for this patient is the heart transplant only. Heart transplant for this patient. Next, moving on to the fourth one, that is your Takotsubo cardiomyopathy. Takotsubo cardiomyopathy is a best known for the broken heart syndrome. Okay, why this is broken heart syndrome? Let's understand. And also known as a stress-induced cardiomyopathy. So suddenly, when the patient, like female patient, most commonly, there will be having the stress factor. Some of the like sudden bad news they will be hearing, or any kind of the heartbroken situation, what happened? There will be a sudden surge of the catecholamines. So the catecholamines will be released from the body, which will be leading to the ATP production, and this ATP production will be completely depleted immediately. Okay, so the depletion is also seen. So all the muscles will be needing to the contraction for the ATP, and ATP is entirely depleted, which will be leading to the these kind of presentation in the patient. So there will be a shape of like this is a Japanese octopus shape, which will be leading to the hypokinetic to the these kind of shape. Heart ventricle should be this shape, but suddenly the heart is depleted due to the ATP, so leading to this kind of shape, leading to the patients with the presentation of the chest pain. What is the symptoms? Best the patient will be appreciated with the chest pain only, no radiation of the pain. And when you do the ECG, the first thing you will be seeing the ST changes. And you also order for the tropi will be also elevated. So the best investigation of the choice for this patient is a echocardiography. On the echocardiography, you will be seeing the shape of the heart and also the hyperkinetic mechanism of the heart. Okay, this is what the presentation. What you can do the ballooning of this condition. Treatment will be control the heart rate and ACE inhibitors and symptomatic treatment only. Okay, never treat this patient with a PCI intervention or any other thrombolysis. Best treat with the underlying cause and the only control the heart rate. That is what your cardiomyopathies, 4 types of the cardiomyopathies. Next, understand what is the heart failure, guys. So heart failure, we already discussed multiple times in the heart failures. So heart failure will be reduced ejection fraction and heart failure with the preserved ejection fraction. So it will be less than 40%. This will be less than 50%. And how this patient will be presented. So this will be systolic failure and this will be diastolic failure. In the systolic heart failure, mostly this will be from the JVP side only. So increased jugular venous pressure, and patient will be also having the hepatic symptoms because the jugular vein coming from the pool of the blood from the hepatic only. So if the heart cannot pump in the right side of the heart, which will be leading to the increased jugular pressure, and again blood will be coming back to the hepatic, and hepatomegaly is seen, and pulsatile sensation of the hepatic will be also seen. So again, coming to the diastolic, what happens? So the left side of the heart cannot pump, which will be leading to the pulmonary edema in this patient. So these kind of symptoms we can differentiate. And also orthopnea. What is the orthopnea? The patient at some position, he will be having the discomfort. And paroxysmal nocturnal dyspnea. What is this paroxysmal nocturnal? At the some points in the night, they will be having the symptoms. Okay. And also recurrent cough in this patient. This is the classical symptoms between the heart failure of the reduced ejection fraction and the preserved ejection fraction. And there is a question, what is the most common cause of the heart failure? Always the most common cause of the heart failure is the hypertension only. And these patients, when they are having the hypertension, which will be leading to the left heart hypertrophy. Okay, left heart hypertrophy, and this heart hypertrophy cannot pump fat. So the fluid overload will be seen in this patient. So if the fluid overload is seen, this will be eventually leading to the BP. So increased hypertension, and this will activate the RAS pathway, and RAS pathway ultimately activate the aldosterone. And aldosterone, what it will do? It will again increase. It will further increase, right? It will increase the sodium along with the H2O. Again, you will be seeing the fluid overload. So this is what the complete mechanism. Instead of you have to reduce, you are actually increasing and worsening the condition of the heart failure. So once this aldosterone is activated, so there is a chance ANP will be released or BNP released. What is this? These are the natriuretic peptides, anti-natriuretic peptides by natriuretic peptides. So these both will be leading to the sodium plus the H2O. These both will be excreted. So that means some point there will be a fluid overload should be decreased. So for that, what is the treatment that we have to give for this patient? So treatment protocol will be, we have to start the patients on the ACE inhibitors. Okay, you have to stop the RAS pathway, ACE inhibitors or the ERB inhibitors. All right. Then after that, to control the heart rate, start on the beta blockers, or to decrease the patient's edema, like pulmonary edema or the hepatomegaly, you have to start on the diuretics. And for the heart function, you can start also on the ionotropes. So the another drug that is very famous nowadays, that is your ARNI. What is this ARNI? Sacubitril This sacubitril is your nephrolysin inhibitor. Along with the sacubitril, the RNA combination is the valsartan. Okay, these drugs. And all these drugs now will decrease the mortality of the patients. Okay, this is what your heart failure. And next, moving on to the valvular heart diseases. So in the valvular heart disease, you have the multiple, right? The most common one, and overall all the valvular heart diseases, the most common one is the mitral stenosis. And in the mitral stenosis, the most common cause for the mitral stenosis itself, rheumatic fever or the rheumatic heart disease. So what are these? You have to understand. Don't have to know each and every valvular heart disease. Instead of that, you have to know only the what are the specific findings of these conditions. In that, you have to know the murmur. So the murmur will be mid-diastolic murmur. Okay, the mid-diastolic murmur will be seen in the mitral stenosis patient. And always remember, you never give the diuretics in this patient. So if you give the diuretics, the condition will be worsened. So the diuretics is contraindicated in the mitral stenosis patient. And how this patient will be presented? Syncope, dyspnea will be presented. Mitral is the valve that is involved right in the left side of the heart. Also, this will be causing the Ortner syndrome. What is the Ortner syndrome? This will be leading to the hypertrophy of the heart, which will be leading to the recurrent laryngeal nerve will be compressed. Okay, on the left side of the recurrent laryngeal nerve will be compressed, leading to the hoarseness of the voice. Okay, you may get the question, what is the Ortner syndrome associated with which valvular heart disease? That is your mitral stenosis. Next, moving on to the mitral regurgitation. What is a mitral regurgitation? So the patient will be having suddenly the valve is closed. Still, there is a chance that the blood is coming back. That is the mitral regurgitation. Again, the cause will be rheumatic heart diseases only. If the mitral stenosis is progressed, that will be leading to the mitral regurgitation. And these patients also same, the dyspnea, palpitation will be seen. What is the murmur? The classic murmur for the mitral regurgitation will be pansystolic murmur. So pansystolic murmur is also seen in which condition? The continuous murmur seen in your PDA, right? Your patent ductus arteriosus. Next, moving on to the other most common, that is your aortic stenosis and the aortic regurgitation. So aortic stenosis patient, the most common cause is not the rheumatic fever or the rheumatic heart disease. This is the most common due to age of the patient or atherosclerosis. Okay, atherosclerosis. These are the two most common causes for this patient. And how this patient is presented as ASD. ASD means patient will be having the pain, angina, chest pain, and recurrent syncope attacks. And patient will be also having the dyspnea. And in this aortic stenosis also, the contraindicated is the diuretics. It will worsen the condition. To avoid that, you have to stop the diuretics. And what is the treatment of, what is the murmur in this patient? So the classic murmur of this patient is the mid-systolic murmur. Okay, next moving on to the aortic regurgitation. In the aortic regurgitation, there is a specific multiple signs will be, that is the most important. The most common cause is the hypertension and followed by the rheumatic heart disease. And this patient will be having the wide pulse range. Okay, the wide pulse pressure will be present in this patient. The murmur will be early diastolic murmur. Early diastolic murmur, which is also known as the Austin-Filter murmur. And next, there will be a specific signs you may have heard, water hammer sign, and also lighthouse sign. Okay, these are the both signs will be seen in your aortic regurgitation. In the aortic regurgitation, now you can give the diuretics. So the patient can be given the diuretics. It can be given. Only the condition that is not given, aortic stenosis and the mitral stenosis of the patient. Next, moving on to the tricuspid stenosis and the tricuspid regurgitation. In the tricuspid stenosis, now this is most commonly due to rheumatic heart disease only. And this patient will be having the mid-diastolic murmur. Okay, mid-diastolic murmur seen in this patient. And in the tricuspid regurgitation, this patient will be having the holosystolic murmur. Okay, holosystolic murmur is seen in this patient. And in the JVP of the tricuspid stenosis, this patient is seen with the Canon A waves. Okay, Canon A waves is seen. In the tricuspid regurgitation, JVP will be seen as a X descent will be absent. And now the question is, in which conditions Y descent is absent? This is the commonly asked question. Y descent is absent. This is seen in the cardiac template. Okay, don't confuse with the tricuspid regurgitation and the cardiac template. Okay, and there is a specific sign that is seen, that is a C wave. Together, they will be combining of the C wave that is seen in the JVP, known as the Lancisi sign. Okay, Lancisi sign. Next, moving on to the pulmonary stenosis and the pulmonary regurgitation. Pulmonary stenosis can be the congenital defect seen in the Noonan syndrome patient. Okay, and pulmonary regurgitation, usually the patient might be having the underlying cause due to the pulmonary hypertension or other pulmonary disease. This patient will be having the pulmonary regurgitation. And how about the murmurs? This patient will be having the ejection systolic murmur. And this patient will be having the Graham-Still murmur. Okay, so you may have confused so far all what is this murmurs. Simply remember like this. This is your this is your isovolumetric contraction followed by the isovolumetric relaxation and again continued by the isovolumetric contraction. So this is your systolic, this is your diastolic. And here your mitral and the tricuspid valve will be closed and your atrial plus pulmonic valve will be open. Okay, S1, S2 and again S1, right? And in this phase, you will be having the mitral and the tricuspid open and the aortic and the pulmonic will be closed, right? So understand that when the mitral valve and the tricuspid valve is closed, what they are going to cause at this point, there will be causing the, when the valve is closed, it is try to regurgitate, right? You will be hearing here the mitral regurgitation and the tricuspid regurgitation. And aortic and the pulmonic valves are open. It has to pump properly, but it cannot pump due to closed valve. That is the stenosis, aortic stenosis and the pulmonic stenosis. Opposite to that, the mitral stenosis is seen here, tricuspid stenosis is seen here, and the pulmonary regurgitation and the aortic regurgitation is seen here. So at least remember this cardiac cycle and their phase. You can easily answer in the examination. If the case is given, in the case the examiner is trying to tell, he have heard the murmur at the left part of the region. It is the systolic murmur. Okay, then you go with the options A, B, C, D. Is there option anything related to the systolic murmur? Then choose accordingly. That is the best thing that you can answer instead of all remembering or the confusing writing. Okay, this trick will be working for you. To the next topic, here we are going to discuss about the kidney and their some of the diseases. So first thing you have to understand, there is a filtration unit in the kidney. So you are specifically when we say the filtration unit is present in the glomerulus. So what is it consists of? So the filtration unit will be consisting of the basement membrane. Along with the basement membrane, the podocytes, which is your food process, and podocytes along with the endothelium. And this endothelium is a fenestrated endothelium, not like other endothelium. This is a fenestrated endothelium. These three consist of the filtration unit of the our glomerulus, which will be having the negative side only. Always it is in the negative energy only. That lead to less chance of microprotein or like protein will be lost from our filtration. So if you want to check whether the patient is having the risk of the protein loss in the body, then you have to do the urinary albumin creatinine ratio test. This is what the test. So microalbuminuria, when I say the microalbuminuria, it is only less than 300 milligrams loss. If I say microalbuminuria, this is more than 300 milligrams. It is almost leads to the end stage renal disease. And this patient will be having the microalbuminuria. This is a warning sign, early warning sign that the kidney is shutting down. Then you have to intervene as soon as possible. All right. Next, moving on to the bilateral or the unilateral renal artery stenosis. What is this condition? Usually, whenever you see there is some stenosis, the most common cause will be atheroma only. So the atheroma formation can be happened here. That is the most common in the renal artery stenosis. And the second most common, it can be genetic. The patient might be having the fibromuscular dysplasia. fibromuscular dysplasia. And what is the symptoms? Usually, if the renal artery is significantly blocked due to atheroma or any block, what is the symptoms? The patient will be having the hypertension, and this hypertension is not controlled by 2 plus or minus diuretics. Still, the patient is on the 2 types of the drugs along with the diuretics. Still, the hypertension is not controlled. This is known as the refractory hypertension. This is known as the refractory hypertension. Then you have to investigate what is the cause of this condition. For that, first the screening will be done. In this screening, you will be doing the ultrasound only. And what is the ultimate choice? The gold standard or the investigation of the choice is the angiogram. So the renal angiogram is the gold standard, whereas your ultrasound is the screening test only. In the ultrasound, we will be seeing the structure like this. So the beaded appearance will be seen. So this is also angiogram only, but in the ultrasound also you will be seeing the beaded appearance. So this is what the overall renal artery stenosis. And what is the treatment? For the treatment, you have to start the patient on the ACE inhibitors or the ARB inhibitors. Okay, along with that, you have to start on the diuretics. So 3 types of the drugs can be given for this patient. So let's say, but the patient is having the bilateral renal artery stenosis. Can I give the ACE inhibitors? In this patient, ACE inhibitors are contraindicated. So remember this point also. Bilateral stenosis, you should not give, but unilateral, you can still give this patient. Next, we'll be discussing the RTA types, renal tubular acidosis. So type 1 and type 2, type 4. Okay, type 3 is very rare and not considerably the significant pathology in the patients. So type 1 is seen in the distal convoluted tubule, type 2 is seen in the proximal convoluted tubule, type 4 is seen in the collecting tubule. So the type 4 is the overall the most common cause of the all RTAs. And what is the causes of this? This is due to multiple myeloma. Okay, same as the type 2 also, this is also multiple myeloma. Both are due to multiple myeloma. And this fourth one is most common cause due to diabetes nephropathy. Okay, diabetes mellitus nephropathy complications. This is the most common cause. And what happened in this specific condition? So the type 1 is affected in the DCT. So the main function of the DCT is the sodium and the chloride. This is what the secretion of the sodium and chloride. What happens when the sodium and the chloride is not functioning properly? This will be leading to the aldosterone activation. If the aldosterone is activated, which will be leading to the sodium increase in the body and potassium decrease in the body. Along with that, H plus ions also lost. So this is the presentation of the RTA type 1. Okay, and this will lead to nephrolithiasis. The patient will be having the risk of nephrolithiasis due to the increased calcium levels also. What is the treatment for this patient? The treatment is the bicarbonate infusion because your H plus ions are going lost. So bicarbonate infusion can be given or the ENaC channel blocker should be given. Next, moving on to the type 2, your PCT, proximal convoluted tubule. So maximum all the ions, glucose, everything will be here only. The other causes of this patient will be Fanconi syndrome. So there is a question also. The acetozolamide. Acetozolamide is a cause of which RTA? That is your type 2 RTA. Same again. So here also all the electrolytes will be dysfunction. This Na is decreasing in the body. Immediately it will be activating the aldosterone. So aldosterone is activated, leads to increased sodium, but at the same time it will be decreased potassium. And same treatment will be given for here also, bicarbonate infusion for this patient also. So this is what your type 1 and the type 2. Next, coming to the type 4, this is quite different. This is happening in the collecting tubule. So your ENaC channel is completely blocked. Okay, ENaC channel is blocked. And next, ENaC channel is blocked. The main function of the ENaC channel is increase the sodium along with the water. Okay, and it will decrease the potassium plus decrease the H ions. This is the normal function of the ENaC. But ENaC channel is blocked. What happens? This is also not functioning properly, right? Your sodium will be decreased and your potassium will be increased, right? Unlike the other, here the situations will be different. In all the RTAs, potassium is decreased. In the type 3 only, the potassium is increased. So for this patient, you have to not give the bicarbonate infusion. Instead of that, you have to treat the underlying cause and maximize that. You never give the potassium sparing agents for this patient. That is the first thing. And also fluid restriction is maintained for this patient. So this is what the RTAs and their types. Next, we will be discussing the glomerulonephritis. In the glomerulonephritis, it is two types. One is the nephrotic, other one is the nephritic. So when I say the nephrotic, it is mostly related to the protein only. So the protein is highly lost in this patient. The 300 to more than 300 also, the patient will be high loss of the protein. And also this will be leading to the edema because of the fluid is going out of the compartments, and lipids also lost. Okay, and protein loss will be also calling this as a hypoalbuminemia, right? This is what seen in the nephrotic patients. And in the nephrotic patients, unlike the protein loss is also seen in this patient, edema is also seen in this patient, but very less comparing to the nephrotic range. And these patients, along with that, they will be a hematuria. This is significantly seen. More than 10 RBCs is also seen for this patient, and there will be a risk of the hypertension. These are the nephritic symptoms. And what are the causes? When I say nephrotic, the most common cause is the minimal change disease seen in the children patients. And FSGN, focal segmental glomerulonephritis, seen in the adult patients. And the MGN, membranous glomerulonephritis, seen in the old age. These are the most common cause in the adults, most common cause in the old age people. When I say the most common in the children, in this nephritic patient, you all know that is your pro-streptococcal glomerulonephritis. In the adult patients, that is your IgA nephropathy. This is the most common causes in these patients. And the question will be asked, overall, the most common cause of all the glomerulonephritis, that is your IgA. Why? Because IgA is frequently associated with the viral infections. So when the patient is having the viral infection, post that any significant hematuria, hypertension, proteinuria is seen, that is most likely due to the IgA only. Okay, this is what we have to understand. And there are also specific findings that you can remember, only pathological or the exam points. The first one is the minimal change disease. What we discussed, minimal change disease seen in the children's, right? This minimal change disease, and on the electron microscope, when you see the diffuse loss of the food processes. The filtration unit, one of the component is the food process, right? If the food process is lost, that is known as the minimal change disease seen in the children. And treatment, this treatment will be best responded by the steroids. Okay, it is steroid responsive disease. Loss of podocytes will be seen. Next, moving on to the MGN. MGN, membranous glomerulonephritis, seen in the old age people, and old age people who are suffering from the HIV positive or hepatitis B. These are the commonly associated conditions. And next, coming to the MPGN. This MPGN is the membranous proliferative glomerulonephritis. Difference between these two is there is a highly chance of the proliferation of the glomeruli, which will be leading to looking on the electron microscope as a tram track appearance. Okay, so there is a question also. Tram track appearance is seen in which one? That is seen in the patients, those who are suffering from the MPGN. Okay, and this is seen with the patients, those who are again suffering from the hepatitis B or the C commonly. And in the MGN, the membranous glomerulonephritis, you will be seeing the spike dome pattern. Okay, spike dome pattern is seen in these patients. Next, FSGN. This is most commonly seen in the adult patients. And for this, there is a specific criteria that is used. That is your Columbian classification. Okay, so the grade 1 or the type A, that is the having the very good prognosis. And those who are having the type F, that is the worst prognosis. Okay, Columbian classification used for the FSGN. Next, moving on to the nowadays, this is the commonly associated diabetic mellitus nephropathy. And this is also associated with which condition, guys? Worldwide burden, that is your CKD. Single most common CKD is diabetic nephropathy. Earliest, when you see the glomerulonephritis changes in this patient, earliest there will be a basement membrane thickening. Okay, after the basement membrane thickening, this will be leading to these kind of nodules. What is this nodules known as? Kemmel-Sten-Wilson nodules. Okay, classic lesion that is only presented in this patient, that is your Kemmel-Sten-Wilson lesions. Okay, next moving on to the two other types. Other one is the your IgA, and next one is your PSGN. So in the PSGN patients, How we know? The patient is having the history of the 1 week of the post-streptococcal infection, right? Post-strep. That's why the patient will be also having the ASO, anti-streptolysin positive will be seen in this patient. And significantly, this patient will be C3 levels will be low. And when you see under the fluorescence, these fluorescence is known as the starry sky appearance or granular appearance. Okay. On when you see on the light microscopy and in the electron microscopy, these patterns. So subepithelial region. So this is your epithelium. Under the epithelium, there will be a subepithelial deposits. Same symptoms. The patient will be having the hematuria, hypertension, edema. So what is the difference between the IgA and the PSGN? IgA is also associated with the infection, what we discussed. So, but this is less than 1 week only. Okay, within the 2 to 3 days post-infection only, IgA is presented. And in the IgA, C3 levels are normal only. Okay, and this will be seen with the linear pattern. Okay, not the granular pattern, it is in the linear pattern only. C3 levels is normal. That is what the main difference between the PSGN and the IgA. And there is also one of the other one, that is your hereditary nephropathy. Hereditary nephropathy is also known as your Alport syndrome. So Alport syndrome has a specific criteria. The triad is seen with the Alport syndrome. One is the lenticonus. So lenticonus means the lens is displaced. And A for Alport, remember this as a anterior. Okay, A for anterior, A for Alport. Anterior lenticonus is seen in this patient. And hereditary nephropathy, one is that the kidney having the condition of the nephropathy, mainly in the basement membrane, type 4 collagen. Okay, type 4 alpha 5 collagen that is involved in the Alport syndrome. And the third one is the SNHL. What is this SNHL? The ears is also involved. So the patient having the eye problem, kidney problem, and also hearing problem, that is your Alport syndrome. And next, another one also, you may have heard good pasture syndrome. So the good pasture syndrome is also affected in the type 4 collagen. And this is your type 2 hypersensitivity reaction. So this patient is usually involves the both the lungs and along with the kidneys. That is what hemoptysis is seen and hematuria is seen. That is what your good pasture syndrome. So our next topic will be endocrinology, associated symptoms, and what are the glands is involved, what are the hormones is involved, and presentations that we'll be learning here. So let's start our first disease with the prolactinoma. So the prolactinoma, the major one, which is going to presented in the, especially in the females. Not only females, sometimes even in the males also it is presented. But let's see what is the most common cause for the prolactinoma. Usually prolactinoma is caused due to the adenoma only. So there is a adenoma in the formation of your pituitary gland. Your pituitary gland will be producing this adenoma, leading to the hyper-excess production of the prolactin levels. Or else sometimes the patient will be taking the drug abuse, like such as your substance abuse, or you see the drugs like metoclopramide. All these drugs will be causing. And some of the other drugs like your haloperidol, okay, risperidone, your antipsychotic drugs, right? These are also can cause the prolactinoma. And what are the symptoms this patient will be having? Like galactorrhea, like milk discharge from the nipples, and also menstrual changes. These are the major changes will be seen, and decreased in libido. Along with that, the patient might be having the visual disturbances. This is the question, why this patient is having the visual disturbances. Because if you see where this adenoma is formation, there is a optic chiasma here. Okay, optic chiasma here. So if this tumor is compressing the optic chiasm, so whatever the nerve root is coming to your eyes will be compromised. That is why whenever the patient is having the visual disturbances, this is considered to be the severe disease of the prolactinoma. Then the treatment should be, or the test should be done here. So what is the screening test for this patient? So the screening test is the visual field test only. You have to check the patient visual field test. And the investigation of the choice, if you see any visual disturbances, then you have to go for the MRI cut. Okay, pituitary MRI cut you have to take for this patient. And the surgery will be ultimate choice for the to decrease the symptoms. If it is a microadenoma, then you can treat the patient with the drug therapy only. So the cabergoline is the drug of the choice for this patient. And those who are in the pregnancy, you can start the patients on the bromocriptine. Okay, these are the two choices that we can give for this patient. And next, moving on to the next disease, that is your acromegaly. So the Great Kali is also having this condition only. So the acromegaly patients, how these patients, what are the main cause of this patient? Usually the excess of the growth hormone. This is the primary cause for this patient, those who are suffering. There is a specific type for the acromegaly, the hypertension. The patient will be having the severe hypertension and increased levels of the insulin resistance, diabetes mellitus. Along with that, viscera involvement is seen that will be leading to the organomegaly. Okay, organomegaly. So this is the triad of the acromegaly patients. Why this is commonly associated in this patient? So when there is a excess of the growth hormone due to any kind of tumor, okay, adenoma of the pituitary gland in the growth hormone, which will be leading to the increased insulin-like growth factor. So these insulin-like growth factor will cause the increased insulin in the body. Sorry, increased insulin resistance in the body, which will be leading to decreased chances of the glucose production, decreased chances of the insulin production, right? And also there is a patient will be having the hypokalemia and hypernatremia, and also patient will be having the fluid overload. Because of the huge body, there is a high chance of the fluid overload also seen. This will be leading to the blood pressure, increased blood pressure. This will be leading to the diabetes mellitus. And IGF will also involve the multiple organs. How this is how the patient will be presented. And what is the screening test for this patient? So the screening test for this patient is the IGF levels only. You have to check the IGF levels. And then the investigation of the choice is the OGTT. OGTT is the investigation of the choice. And the treatment of the choice is the octreotide. This is the acromegaly overview. Next, moving on to your ADH hormone. So ADH hormone is mainly for the, which is also known as your vasopressin hormone. Why? ADH is for the water retention. So whenever in the collecting tubules, it is on the aquaporins, right? With the help of the aquaporins, this is going to activate it, and this will do the water retention as a main mechanism of action. So when I say the ADH is in the excess, okay, ADH will be having the excess in the body. So that disease is known as the SIADH. SIADH means syndrome of inappropriate ADH present in the patient that will be leading. The most common cause is the paraneoplastic syndrome associated with the lung cancer in the patient. Okay, and what is happening in the patients of the SIADH? There is a more and more ADH, right? This will be leading to the more and more water. So this water will also attract the sodium, and this is going to hypervolemia in the patient. Once the hypervolemia is settled, this is going to trigger the patient's hypertension, fluid overload, and the patient will be having the severe cardiac instability. So it will trigger the release of the brain natriuretic peptide and also atrial natriuretic peptide. Further, it will decrease the sodium by excreting natriuretic peptide. So the sodium will be excreted from the body. So again, here also from the hypervolemia, suddenly the patient will be having the hypovolemia because sodium is going along with that, the water is also going out. Once the water is going out, again it will trigger the ADH hormone. So again, the water will be retained, which will be reaching until your euvolemia status. Euvolemia status. Here you can see the patient is started with the hypervolemia and then again into the hypovolemia, then reach to the euvolemia. But where the risk is majorly, when the sodium is going out, this is the major cause of the patient death. Okay, cause of death is in the SIADH mostly due to the hyponatremia. Why? This hyponatremia, if it is going into the severe times, that is going to lead to the cerebral edema. If the cerebral edema is formed in this patient, high chance that the patient might be having the neurogenic shock. So that's why this condition can be very high mortality with the hyponatremia. The diagnostic test for this patient is the water loading test. water loading test. And the treatment, you have to give the Vaptans. So the Vaptans is going to block the ADH. That is the treatment of the choice. Next, moving on to the your diabetic insipidus. This is not diabetic mellitus. This is your diabetic insipidus. What is the diabetic insipidus? When I say diabetic insipidus, this is the ADH where hormone is not working properly. Instead of the retaining the water, this is not retaining, which will be leading to the what are the symptoms? Polydipsia. The patient will be having the thirst of the hunger, and also patient will be having the polyuria. DI is subdivided into the neurogenic. So it is in the central or it is in the nephrogenic. Basically, your ADH is coming from the pituitary and going to act on the kidney. Same as here, pituitary and the kidney. So neurogenic, in the pituitary itself, ADH is absent. Okay, ADH is not working. So you can treat this patient with the same desmopressin. Vasopressin, other formation, desmopressin. Instant relief can be seen with this patient. But it is in the nephrogenic. ADH is normal only here. ADH is normal only, but the kidney cannot pump properly. For this patient, you can treat with the thiazides. Okay, so you have to know the cause, which one is the culprit in this situation. And the test that we can perform in this patient is the water deprivation test. Okay, water deprivation test. Next, moving on to the adrenal gland. Adrenal gland have the multiple diseases and very confusing, but you have to answer this very carefully. When I say adrenal gland, this is having the three types of the layers and inner medulla also going to produce. So the first thing in the cortex region only, the mnemonic for the remembering the hormones GFR. So outer to inner side, glomerulus, fasciculata, and the reticularis. The glomerulus is producing the aldosterone, outer side, and the fasciculata producing the cortisol and the cortisone. Reticularis producing the testosterone and the estrogen. And your medulla is going to produce the catecholamines. What are those catecholamines, guys? Your epinephrine and the norepinephrine. So if when the situations like epinephrine, norepinephrine will be high, so situations like your flight and the fight situations. Only these times your epinephrine, norepinephrine will be high chances. So if the medulla is involved, in the medulla, commonly there is a condition known as a pheochromocytoma. So this patient is having the pheochromocytoma. And this is having the 10% rule. What is this 10% rule? 10% of the patient will be having the bilateral pheochromocytoma. 10% patients will be having the malignant condition. 10% will be having the extra-adrenal. This is what the 10% rule of the pheochromocytoma patients. What is the main culprit of this patient means? When the catecholamines is increased, sympathetic nervous system will be increased. So this sympathetic nervous system will be increased and causing the patient sudden onset of the headache. Along with that, patient will be having the BP fluctuations, and along that the patient will be also experiencing like palpitations, flushing. These symptoms will be presented, and these are recurrent. Okay, frequent and recurrent the patient will be seeing. For this patient, the treatment will be ABC. What is this ABC, guys? You have to start the patients on the alpha blockers, like your phenoxybenazine. This drug can be given for this patient. Followed by, you have to give the beta blockers, then followed by the cure. What is the cure? Whenever you see if there is a tumor, what is the major cure? That is a surgical procedure. So you might be seeing the question answer. What is the first drug of the choice? You have to give the alpha blockers, then followed by the beta blockers, then followed by the cure. For the diagnostic test or the investigation of the choice for this patient is the metanephrine urinary assay. Okay, metanephrine urinary assay is the investigation of choice for this patient. Next, moving on to the next, so we have already completed the inner layer. So the medulla is already completed. Now we are moving on to the outer side of the cortex hormones. So the first one is the Cons syndrome. What is the Cons syndrome? This is a tumor. So this is the tumor of the glomerulosa. In this patient, the aldosterone is produced more. Aldosterone is very, very high in this patient. So the major function of the aldosterone is increase the sodium levels. So that means the patient is having the hypernatremia. So it will block the potassium. So the potassium will be low, hypokalemia. When the potassium is also blocked, the H plus ions is also lost. That will be leading to the metabolic alkalosis in the patient. And when the sodium is involved, this will be leading to the H2O. That will be the fluid overload, leading the blood pressure, high blood pressure in this patient. These are the major symptoms of the patient. Okay. And what is the investigation of the choice for this patient? Saline infusion test. Because of the fluid overload, you can do this test, saline infusion test. The treatment of the choice, aldosterone blockers. Okay, so aldosterone blockers like such as your spironolactone, those drugs can be given for this patient. Next, moving on to the cortisol is now, so what we discussed, there is a increased of the aldosterone. Now we are discussing on the decreased of the entire adrenal insufficiency. Not only just the cortisol, here entire cortisol, aldosterone, and also inside the sex steroids, all this will be decreased in the Addison's disease. So this condition commonly associated with the idiopathic one. But nowadays, due to the autoimmune conditions, the most common cause is the autoimmune. So it is also associated with the infections, such as in India, the Addison's disease in the TB hospitals or the chest medicine most commonly associated. In the foreign countries or the Western countries, HIV is the most common. Okay. And there are some conditions like Neisseria meningitis. There will be a high chance the adrenal hemorrhage, sudden onset of the adrenal hemorrhage will be presented, right? So that way that the patient will be having the adrenal crisis or the Addison's crisis. Okay. And how these patient will be presented. Opposite to that, your aldosterone. Aldosterone is not working. That means hyponatremia, hyperkalemia, and metabolic acidosis is seen in this patient, right? And patient will be having the dehydration. This is the how the formation is presented. Now, cortisol is not working in this patient. So the cortisol is not working, then the patient will be having the hypoglycemia, and patient's sex steroids are not working. That will be leading to the hyperpigmentation, and also patient will be having the libido changes. These are the presentation of those patients, those who are suffering from the Addison's disease. And investigation of the choice for this patient is the ACTH stimulation test. Immediately, the treatment will be IV hydrocortisone. Okay, this is the treatment of the choice for this patient. Next, moving on to the last one, that is your Cushing syndrome. What is the Cushing syndrome, guys? Cushing syndrome is related to the, again, paraneoplastic syndrome, mainly your lung cancer. But Cushing syndrome can be secondary also. What is the secondary causes? Like your pituitary adenoma. When it is associated with the pituitary adenoma, you have to call this as a Cushing disease. Okay, not syndrome, Cushing disease. And Cushing syndrome is also nowadays, when you see in your OPD or in the practice, you will be seeing the iatrogenic causes, means misuse of the steroids. So usually the quacks or the RMPs, they will be giving the multiple steroids for this patient. So that will be causing the Cushing syndrome. How the presentation, the patient will be having the excess hair distribution, the fat buildup. Immediately the patient will be having the muscle loss, easy bruising, amenorrhea changes, and also abdominal. This violaceous stria is present in this patient. Thinning and loss of the hair is also seen. These many symptoms, and if you progressively use this condition, that will be leading to the weakness of the bones, and fractures can also happen in this patient. This is what Cushing syndrome. Moon face is also presented. This is also known as the moon-like faces. For this patient, the investigation is the dexamethasone suppression test. Dexamethasone suppression test and treatment, taper the steroids. Never stop the steroids suddenly. If it's an iatrogenic cause, taper the doses. And along with that, you can also start on the ketoconazole. Those who are having the minor role in your steroids pathway, then you can add these kind of drugs also. Next is our thyroid diseases. Thyroid diseases, usually the TRH coming from the hypothalamus is going to stimulate the TSH, the thyroid stimulating hormone. And this will be stimulating the T3 and the T4 in the thyroid gland. So when the T3, T4 reach the normal level, it will send the signal to TSH to stop, and it will also control. And again, TSH will send the signal to the TRH to stop. So all will be reaching the normal points only. This is how the presentation, negative feedback mechanism is commonly seen in the thyroid synthesis. But in the presentations, how this laboratory changes that you have to interpret. So let's say this condition is the hypothyroidism. So hypothyroidism that is seen in the thyroid gland. Thyroid gland is produced by the T3, T4. So the laboratory ranges of the T3, T4 is low. So what the TSH is thinking, so the T3, T4 might be slow. So it will send the signal immediately like positive mechanism. So high TSH is seen in the blood because TSH is try to compensate that the T3, T4 is low. That is what the mechanism is seeing here. So let's say this is the primary hypothyroidism. This is what the results. And over that, if it is progressed, what happens? The TSH is also going to come down because of progressively it is producing right again and again. That is why it is also going to decrease. This is your secondary hypothyroidism. And moving on to the hyperthyroidism, opposite to that, hyperthyroidism, T3, T4 is more. So it will send the signals back to the TSH. So TSH will come down. Might be the T3, T4 is normal. That is why I have to decrease. This is how the TSH will be presented in the primary hyperthyroidism. Secondary hyperthyroidism, again, both will be increased here. And there is also other type, that is your subclinical type. In the subclinical hypothyroidism patients, this will be normal, but your subclinical TSH will be high. And subclinical hyperthyroidism, again T3, T4 will be normal and TSH will be low. This is how you have to remember and the interpret in the examination. How they are going to present it. Your hypothyroidism patient will be having the alopecia, patient will be having the dry skin, slow heartbeat, because the main function of the thyroid hormone is the basal metabolic rate. If the basal metabolic rate is slow, constipation can occur, dry skin can be seen, and alopecia because of the circulation is poor, cool and crampy extremities also presented these patients. And next, coming to the hyperthyroidism, basal metabolic rate is high. Patient is having the diarrhea, tremors, tachycardia, and increased appetite, abnormal weight loss, libido, and increased sweating. All this will be seen in this patient. This is how the different patients will be presented in the hyper and the hypothyroidism. What are the causes? The most common cause is the Hashimoto's. And the most common for this, Graves' disease. What is the drug of the choice for this patient? Hashimoto's, you have to give the Thyronorm. Okay, Thyronorm is the drug of the choice for this patient. And coming to the Graves' disease, methimazole is the drug of the choice. PTU. PTU is given in the first trimester of the pregnancy because methimazole can be the, this can also cause the patient suffering from the pregnancy patient. It can cause the teratogenicity in the baby. That's why we should avoid the methimazole or the carbamazole. And antibodies. So when it comes to the antibodies, the most common antibody involved in the Hashimoto is the TPO antibodies and the TG antibodies. Okay, your thyroid peroxide antibodies and the thyroglobin antibody. And in the Graves' disease, involved thyroid receptor and thyroid stimulating hormone receptor. These are the antibodies that is involved in the Graves' disease. And what is this condition, guys? This is the classic presentation of the primary parathyroidism. Okay, excess of the primary hyperthyroidism is this condition. How this patient is presented mostly due to the adenoma or the paraneoplastic syndrome. This patient is having the increased PTH, which will be eventually leading to the increased calcium. And this is how those presentation is seen. This presentation is known as the brown tumors. For this patient, what we have to do, the technetium perchinate is the only choice that you can do as the investigation of the choice for this patient. And if the calcium is increased along with the brown tumors, the patient can also have the kidney stones. And also patient will be having the bone pain. This is the recurrent condition will be presented. Okay, this is what we have to treat these patients. And the drug of the choice for this patient is the ivadronate. You have to give the bisphosphonates for this patient to treat this condition. Okay, this is what your renal, nephrology, endocrinology, and the cardiology. Please go through this once again and read each and every point. Very, very important for your examination. And please do access to our new RR notes. This is the best notes that I can recommend for you. And please do subscribe to our YouTube channel. Soon we are going to update the expected topics and the rapid revision of the other subjects.